name is Gerardo Villarreal. I'm one of the faculty members working at the VA. And it's a great pleasure for me to introduce our speaker, Dr. Melinda Thiam. I'm going to tell you just a little bit about her background. Dr. Thiam completed her undergraduate at the Pacific Lutheran University with a BS in biology. Then after that, she joined the military and attended medical school at the Uniformed Services University in Bethesda, and then did her internship and then residency at the National Capital Consortium, which is also known as Walter Reed. And after that, she served in the military for a number of years, including working at Fort Jackson in South Carolina, where she got different positions from medical officer to chief of a clinical section. After that, she did some work in private practice and work at the Columbia, South Carolina VA, and she was a research psychiatrist there. We were lucky to hire her in August of 2022. And Dr. Thiam has a variety of interests, including neuropsychiatry and women's mental health. She has numerous presentations, 4 peer-reviewed publications, and 11 book chapters, including being editor as a book on prenatal mental health. Since coming to New Mexico, she's brought a lot of interest and focus on the issue of headaches in our veterans, and which is really a big problem, which is often undiagnosed and undertreated. It's often not treated by PCPs or referred to neurology. And we often see this triad of veterans with PTSD, mild TBI, and headaches. And so Dr. Thiam has really been an innovator using different methodologies, including mobile neuromodulation devices, and is doing a PI project to address this problem in our veterans. And she is certified in headache medicine for non-neurologists. So without further ado, welcome, Dr. Thiam.
All right. Let's see. Great. Are you guys able to see the screen that's moving?
Yes.
Okay. So good afternoon. So I am Dr. Thiam. So it's my honor and privilege. I'm really excited to do this. So again, I actually got to work both sides as a active duty psychiatrist and as a veteran, and as a so I've been on both sides as an active duty person, as well as a physician, as well as a veteran, and well as a VA provider. So that's one reason why I'm so passionate about this. So one of the things we always do in the military side, we always have to give a disclaimer. And so I always like to say it that even though I worked for the military, they stand behind really nothing I say. I have no disclosures for this. And so these are the objectives. I know they were sent out, so I won't read that. I will give the also disclaimer that I have a lot of slides and there are a lot of pictures I will not get to, so I won't necessarily be covering all of it. But I wanted to have all the information in there because we'll have those available if anyone's interested. And so there's a lot of migraine memes out there. And so again, I have a lot of transition sides for this one. So one of this is, if I'm a psychiatrist, if I work in mental health, why should I even be caring about headaches? Because why is this important? And so one of the issues is really looking at this as a chronic pain issue. And if you guys can see the memes here, this is something about migraine. And if any of you have had a migraine, I don't know, has anybody here had a migraine or a headache themselves? I don't imagine anyone's gonna necessarily respond, but some of these ones were from patients where it says migraine makes repeatedly being hit in the head by spinning fan feel like a thrill park ride. Another one was migraine is like having battery acid poured on your brain, being hit in the head with a hammer, all while having a hot poker planted in your eye. So these are a lot of vivid descriptions about migraine. And so that kind of gives you a very interesting description of this. So one of the other things too is our population. And so when I say our, I'm talking about the veteran population, is incredibly high population of headaches due to the nature of what we do. And so due to that, I'm actually going to kind of show you through that and through cases. We also know that veterans have a high suicide rate. And I'll go through that here. And so it is Headaches are part of a neurological condition. As psychiatrist, a part of our boards is neurology, and so it is actually a very relevant issue. We treat PTSD, and this is a very huge association with PTSD. Again, I know sometimes these memes can't all show up. So if you see this, it also says migraine is all the effects of a hangover without the fun of getting drunk. And so you'll be seeing through all this. So again, these are a lot of statistics. I won't necessarily read all of this because I want to be able to get through the rest of it. So one of these things I want to do is present cases. So again, I'm making these artificial names. So Tommy is a 40-year-old Army veteran. So he was an 11 Bravo. For those of you who are not familiar with it, this is called an MOS, or military occupational specialty. That's an Army term. Each service has a different term for what they do in the thing. So this means he was infantry. These are the door kickers, is what we fondly called them. So in the fall of 2000, he joined. Says, 2001, that's when the ivory towers fell. And so they go to Afghanistan. So he joined, so he was medically retired from the military. So if for those of you who've ever had a patient come in, I chose this picture because he comes into your office for mental health. He's being seen for PTSD. In his chart, he's being seen for OCD, and he comes in with a pair of glasses. Although he reports PTSD, he explains he wears his glasses to mental health because he has a lot of head pain, nausea, and then one of the big issues is problems with vision tracking. And this is something I'll be talking about later on. And so one of the big things too is I always refer to, especially our Marines and our infantry guys, a lot of these join in, as early as 17. These are like grade 13. They love video games, but once they go into the military, they can't play video games anymore. And so they start, because they feel like they're going to throw up. One of the things for Tommy is he has a hard time hearing. He actually went to go get a hearing exam. And as he is sitting there, he hears the examiner say, "Your husband doesn't have a hearing problem. He just has selective hearing." I'll go through this a little bit later. And so what's written in his chart is a PTSD headache. And that's what he's told he has. And so from when he retires in 2004 until now, which is 2003, or sorry, I'm blanking on my years, 2023, he's been struggling with this and nobody's been treating him, is what he says. And so as a psychiatrist, and you work with veterans, and the most important thing, and again, as a military psychiatrist, you need to take a military history. So Tommy was a door kicker. So when he was deployed, the infantry used a lot of armored vehicles called Strikers as well as Bradleys. I actually put a picture of that in here. This is a Bradley. And so when they were driving on their combat deployment, they did a lot of urban warfare. And so they get a lot of ambushes, they get a lot of things. And so what happened to his vehicle, and I'm going to simulate this with a wire, see if I can do this. Extra wire. So his vehicle's driving along. I'm going to pretend this vehicle is the brain. And so they're driving along and there is a trip wire, but it's at the height of a tank. And so, or at the height of the Bradley. So they're driving along and they can't see it. And so all of a sudden his NCO, his shorter, so his helmet flips off. But Tommy is taller, so his helmet gets pinned. And so all of a sudden he's getting pinned against this back part of the Bradley, which is called a turret, and the vehicle continues to move forward. So as you now can imagine, your vehicle's moving forward as you're continually getting your head pinned against this vehicle. This NCO is frantically yelling for the vehicle to stop and back up. Meanwhile, they finally stop. Right before he feels his head's going to get completely crushed. And it's to the point where you see these helmets are about 8 pounds. They're supposed to be able to stop a bullet, but it got so bad where the wire actually caved in and he had to get his helmet replaced. He describes this as sun looked different, colors looked different that day. But did he get treatment? No, he's at NCO. He's told, you got to stay here with your men because people will die. This is something that's told to a lot of our guys if you leave. So a couple of weeks later, a grenade goes off. It's called a flashbang. With shrapnel, goes off about 5 feet from him. This one peppers him with shrapnel. It's to the point where his throat gets thrown down. He can't hear. He's stunned. It's to the point where he has to get dragged into the bunker. Other of his men are being told, we got to go. They're actually evacuated. His NCO looks at him and goes, if you leave with everyone else, your career is over. And he says that's all he needed to hear. And so he did not get medically evacuated. And so the headache disorders, I'm going to kind of go back to that case, are your 3 type of primary headache disorders. You have something called the trigeminal autonomic cephalgias, your migraine and your tension. I will go into these a little bit more, so I'm not going to go into them later. You're going to have some pathology where, again, I'll go into this a little bit later, so I'm introducing this. And I have it here because I'm going to go into a little bit later here, and then there's something for other ones. So I really wanted to give an introduction to the history of like the military specific risk factors. So there's something called the polytrauma triad, and I will kind of go with this one. But what I really want to talk about is before they become veterans, what is this about the military? So they have these military values: service, competence, sacrifice, and mission, and collectivism. So as well as your different services. Of note, the Coast Guard is not technically a department of the DoD. It's one of the Homeland Security. And then we have, this is the introduction to the military family. I'm going to go fast through this, mainly so we can get to the other part. So your active duty service members, when they're there, they've done surveys with their top problems. So they're really concerned about maintaining their career, they're really concerned about their loyalty to their service and to their other men and women and their comrades. And so when they get out of the military, going from the active duty, from civilian to the military to veteran is not equal. So we'll see this later on. There's a lot. So when they're active duty, they have a lot of these challenges they're dealing with, as well as the physical challenges. So when we get to the polytrauma triad, this refers to something called the TBI, this calls as well as PTSD, as well as chronic pain, oftentimes headache. And so we often think of blast as not that big of a deal. And so I'm going to get my little head here. So they've actually found the Department of the DoD TBI Center of Excellence has found a lot of blast matters. One thing I will say is think about what we do to a kidney stone. We blast a kidney stone with a tiny little ultrasound wave. Now look at all these things that they're doing. I don't know how many of you go out and shoot a weapon regularly, but that if you've ever shot a weapon, there's a kickback to even a small little pistol or a shotgun. Now you're doing this regularly. And so low-level blast matters. Now these people are being shot at. You have things going against you. So things are being blown up. All those blasts matters, and it starts to accumulate. And not even counting for combat, injuries can happen outside of this. Our service members are participating in a lot of highly risky activities. So the other thing is you find people who are willing to go on these missions. They also tend to be very risky. They join the military. Our infantry guys, our Marines are particularly, when they get bored, they tend to do very interesting activities. They're like high schoolers. The famous words that they always say in the military is, hey, watch this. I had a Marine who said that his command actually decided to take a soccer, a non-combat, non-touch game, and turn it into a combat game. They decided to put all their combat gear on stateside and play tackle soccer, full in combat gear. I had a comrade who, Marines got bored downrange and decided to play football with rocks. And he said, that's not safe. You guys don't have any gear on. And so they decided to go put on their full combat gear and play football with rocks. And so these guys get a lot of injuries too when they're bored. And so again, it's not even just the being blown up. They're the car accidents. Number one cause of TBI in this country are falls. And that can easily happen. I had a paratrooper who they intentionally fall. They have to drop from a 10-foot and learn how to fall. And if they miss falling correctly, you just fall on your head and oops, hopefully you don't break it, because they are supposed to learn how to fall repeatedly. So physiology, you have a very soft brain like this and a hard skull. And no matter how you do this, it's shooken up. And so I think we tend to forget this, and that can be from a blast injury or anything else like this. And so what happens is you have this massive release of this chemical called CGRP. And that leads to massive release of glutamate and inflammation and cell death. And so this is from here. And so this is a blast one, what you see. And this is also where you're swinging the head back and forth. Just with the blast injury, if you look at the lower right corner, you're going to have this part where you see how much the blast basically explodes through the entire brain. It's not just the blast. You have something called diffuse axonal injury. And so I like to use this one because a lot of people say, well, you couldn't have had a head injury or a TBI. Your MRI is normal. And I like to say, well, think of the phone cord on this one. So if you've ever tried to charge a phone cord, that's what the neuronal shearing is. So these little cords right here, if you look at them here, these all have insulation just like myelin. And so if you've ever tried to plug in a phone cord and it didn't work, you may have looked and see if it has damage. It didn't have damage. You're like, okay, it's good. And you continue to plug it in and plug it in until you eventually concede that it is still damaged, even though you can't see it. So that can often happen with TBI. Even though you can't see the damage, it is still there. MRI cannot catch everything. And so that's a big thing we see with this too. And so you also have a lot of symptoms that cannot be explained. And so you have, when the brain is injured, one of the big ones is your vision symptoms. And so these are a lot of your visual symptoms that you'll see. I'll go into this more later. So I'm going a little bit fast on this part right here. And so one of the biggest things that we see with trauma is that post-traumatic headache. So if you imagine your brain is getting shook up, one of the biggest things that we see, people will say, well, you can't still have a TBI because that happened many years ago. In the words of Dr. Alan Finkel, who's an expert in PTH, if somebody has their leg amputated many years ago, we don't stop calling them an amputee. They still have an amputee. So if someone had a TBI, usually the aftermath of that we still see, they still had one, they no longer cease to have one just because they're starting to heal from it. And oftentimes one of the markers of that persistent symptoms is the post-traumatic headache, as well as we see that depression, and then oftentimes it comes with PTSD. I had a Marine who got knocked out when he was downrange. He's with his unit, with his Marines, and his point man actually stepped on something and stepped on an IED. And what happened is there was an explosion. He gets hit with something, gets knocked out, comes to, and to his great horror, he discovered it was the severed foot of one of his Marines. So you can imagine the PTSD symptoms around that one is going to be pretty traumatic. And we can think about this with our individuals who've had bodily harm, MST. I had another female who was attacked within a significant other where she's thrown through a wall. So every time she has a headache, that's going to be triggering the PTSD. So these are very well established. So we see this with PTSD here. And so there's something called moral injury. And so there's a saying in the military, I've got your six. For those of you who've never been with the military, in the military, we always travel in a clock facing direction. So that means you're going towards a 12 o'clock. And so if you're going towards 12 o'clock, 6 is in the rear. And so it's a way of saying, I have your back. Fortunately, that doesn't always happen. And so moral injuries, like for the betrayal from the command, this is people who are supposed to have your back, but they don't. Whether this is the leadership that's betraying somebody or a high stakes one, these are people, this is a huge part of PTSD that almost gets hidden in a way. So we see this with the military. These are people who were in a leadership position. They had to make decisions that, I call it the Sophie's choice type decisions. Like they had to feel like they had to make decisions where life and death decisions were made on them. They may not have actually been in life's way, but they were the ones who made the call to have the shell come down and it killed the village. And they feel responsible in this one, or they bear witnesses to transgressions. So I think of a soldier who they built a village, in Afghanistan, and then they witnessed it being destroyed by the Taliban afterwards, or they could not intervene with things going on. I remember one of them at the Shia Law in Afghanistan in the Middle East. They're apparently with a female, looks odd at the male, they can go ahead and stone her. And, there are soldiers who have reported witnessing the Sharia law being enacted where they will set a woman on fire and they have to witness that and they cannot intervene. That's a huge example of moral injury when they do that. Or let's see things like that happen to kids. And so then you have your MST here. So when PTSD and migraine occur, you have worse symptoms. Same thing with depression. It's now getting into more of the general mental health because I want to be able to get into the regular headaches. So again, you have problems, migraine and depression. There's a huge association with this. We see this with our regular patients, even outside of the military. And so there's actually a link to a lot of genetics with this one. We actually just published an article on this one. So with depression, they're actually 2 to 4 times they're looking at it as a bidirectional rate. There's a lot of interest from the Headache Center of Excellence. Bipolar is a very, very high rate of this one. Just having a family history of bipolar increases your rate of having a migraine around 5 times. They're both hyperexcitable brain. This one, you're also more likely to have a rapid cycling one. Individuals with bipolar, if you have, migraine can trigger and make bipolar unstable and vice versa. So it's actually very important to find out if your bipolar patients have headache because they can actually trigger one or the other. Anxiety, we'll see this, and I'll be getting to this later because individuals with anxiety can cause migraine. Migraine can cause anxiety, especially the vestibular one. ADHD and autism. Autism is also, especially with Asperger's, now turned into autism is sensory sensitivities and hypersensitivity. So it's a huge relationship with migraine. Same thing with ADHD. Substance use disorders. And so this one is not as much because a lot of people say, I'm doing this for my headache. And then women's health. I wish I can do a whole lecture on this, and we're hoping to actually present one like this later on. And so migraine is actually more prevalent in women. And so there is a huge association with estrogen and migraine. And so we see this a lot with, premenstrual disorders. With depression, estrogen goes along with the hormone. And so they're actually more likely to experience longer headaches. They're usually when the estrogen goes down, the hormones, the migraines can go down too. So in periods where you see increased rates of reproductive mental health problems, you can also see the problems with the migraine. And the challenge is you all see this with women's health, where women are actually also less likely to be believed when they do seek help. I'll go into this a little bit later with the case. And then the other challenge is just like your perinatal mental health disorders, a lot of times it's if you're pregnant, all bets are off. You're not supposed to get treated for mental health. You're not supposed to get treated for migraines. They're essentially, in the military terms, they say the Army has a term called suck it up, just kind of deal with it. And you're expected, it's just a headache. Don't worry about it. You're pregnant. That's all you're supposed to care about is the baby, even though it's actually very important to what actually both your mental health as well as your risk. There is an idea that the migraines go away during pregnancy. That is not the case. If they do get better, just like with depression, they tend to come back with a vengeance in the postpartum period. And so with here, I want to be able to make sure I can get through all of this part into the other part. So you have 2 types of main migraine. You have with and without aura. And I'll go into that a little bit later. And so these are different ways to kind of elicit a headache history, as well as something called a HIT-6, which is actually some ways to actually look at the severity of the headache. And so I want to show this part because this is your standard part of the migraine. So migraine, oftentimes people focus on the head pain. And I'm going to show this right here. We often think about it as 4 cycles. The prodrome, also known as the premonitory symptoms, your aura, which may not happen for everyone, your headache, postdrome, and interictal. Now, if you notice, of all these 5 phases, 80% of them do not have the headache part. And so that's what I really want to focus on, because in primary care, if they do focus on the headache, they'll say, how many headaches do you have? But what part that really causes a lot of the challenges in the quality of life are actually a lot of these other symptoms, that other 80% of where they live in. And so this is one of the ones that my colleague made, one of the other psychiatrists from the Jefferson Headache Center, who's actually headache qualifying. And so Now I want to get to kind of the meat of this, which is actually going into the headache disorders. So the prodrome, also known as premonitory, this can actually last up to 72 hours. So these have all kinds of symptoms associated with it. This can actually present a lot of mental health symptoms. So a lot of people can have a sudden onset of anxiety, depression, sleepiness, neck pain, sudden mood changes, brain fog, and actually sign as headaches. And weather can trigger this. And so these are the first symptoms that can actually herald the onset of a migraine and actually be incredibly disabling. And I'll just go into these a little bit more. So the hypothalamus, you can have sensory problems. So individuals can have these sudden onset of sleep attacks. So they're fine, they're awake, and they just feel really, really sleepy. Because the hypothalamus kind of helps kind of regulate a lot of it. Also regulates the thirst. They can get really, really thirsty. They might have to all of a sudden feel like they have to start drinking lots and lots of water. They have to start peeing a lot. They might get screened for diabetes. If they start having a lot of these things, they might start feeling like they're having hot flashes. And so again, they're like, oh, now they're anxious and they're feeling like they're having a panic attack in this symptom because they have a sudden onset of flushing, feeling really warm, and then when they don't know what's going on, they're interpreting that as I must be having panic. And so they're having perceptions. If you look at this, they can actually have autonomic symptoms where you actually start getting really, really nauseous as well as increased heart rate. So you also get neck pain in here. And so oftentimes we think of this as a cervicogenic headache, but this actually can last from the prodrome all the way throughout the migraine cycle. And is often thought to be part of the headache attack too. And so this can actually go from, a lot of people will describe it as, oh, it's not a headache, it's just neck pain. But actually it can be part of the migraine symptom or a migraine herald in this sense. And so they found over 69 to 70% of individuals will have this. And so you can actually palpate the headache or the neck. They'll also find out different areas of right here, which is your trigeminal nerve. They can palpate this in chronic migraine sufferers, and they will find out that some of them that, especially if they get really sore in the chronic migraine, they might be sore all the time. And the person with episodic, which means they have less than 15 headache days a month, that might be signing that they're in the prodrome period and they're starting to get a headache. And so next one is a brain fog. So this can be one of the most disabling ones. And so this mimics depression, right? So they're anxious, their mood symptoms, they're tired. These are a lot, again, they're saying, oh, well, this just must be depression. This little picture here is actually a meme that they sell t-shirts with. I don't know why you necessarily want it, but this can cause huge problems, and they feel, lack of better terms, stupid. They can have a problem with feeling like they can't get their words out. They have, if anybody else has struggled with this, you might have this where you're trying to ask a question, especially when it gets to the aura. I'll describe this a little bit later, where they're trying to do things, and if anyone's had this and they try to do math, they're trying to write notes, they're trying to do things, they just feel like they cannot focus. And this can be incredibly disabling. So even they might be able to deal with the pain, they might be able to do the other ones, but the cognitive ones can be incredibly one, because it's like, but the lack of better terms is where they call it the migraine fog. And so the other one here is the anxiety. You can actually get this one. So again, they're like, oh, well, it's just stress. Stress causes the migraine. This is the one that causes depression. And I love this little one that says stress does not cause it, just like everything else, it makes it worse. And I use this as the click happy thing on your computer. If anyone has had that where you have your computer starts giving you that circle of doom, you cannot keep clicking on it or it will slow down. So if you click on it, does that mean your anxiety has crashed your computer? It doesn't. So that, or let's say you're waiting for the elevator, you're kind of a little in a hurry, and you push the elevator button too many times. Did you stop the elevator from working? You might have made it a little bit slower by hitting it too many times, but you did not cause the elevator to malfunction. Correlation does not prove causation. It's the brain disorder. It's not stress. Is like pouring the gas. It might pour gasoline onto an already going fire, but it is not the fire. So often individuals kind of get blamed for this. And so they're told their headache is actually due to mental health, but mental health will make everything worse. And so this is the number one thing, if you can take this away too. And so abdominal pain, nausea, there's a huge one. So migraine is a full body disease. And so they actually have serotonin receptors in the gut. And so these actually are released and so causes a lot of problems. There's something called cyclic vomiting symptom or abdominal migraine. Individuals might have this as a kid. People who've never had headaches might present with this. They might not have the headache. They might just get really bad nausea and vomiting all of a sudden. They might skip the headache cycle because migraines, some don't always require head pain. They might get the light sensitivity, they might get the brain fog, they might get all the other stuff, and then just get horrible, horrible nausea here. And so this is something that GI gets aware of, and you'll see this as we get along with some of these other symptoms. And so light sensitivity is another big one here. So photophobia during the attack, as well as interatrial symptoms. And so photophobia is sensitivity to light, it's pain from in the eyes, and it can actually be exacerbated by this. And it can, oftentimes it makes them want to leave to go to a place that's dark and can make color and all kinds of other things look abnormal. So if you're able to read this, I'm impressed. So this says, this is what reading is like when I have a migraine. If you can read the words below, I am impressed. You're actually not supposed to. So that's the point, is that what happens when individuals get migraines, they actually can have problems with vision disorder. So it's a binocular vision disorder. And so I will go into that in a little bit. But they can have extreme aversion to light, especially with things that is flickering. So what flickers are your fluorescent lights, aversion to patterns, changing patterns. And so different things like this can happen, things that are responding, and we'll go into that in a little bit too. So different types of color change can be very aversive to individuals with migraine. And so this is a big one too. So binocular vision disorders. So we'll see this especially for those who have a history of head injury. So for individuals with migraine who have eye tracking difficulties, we'll see this one. And so I can actually show this because I can actually do this. So when you're doing this one, you can actually ask them, do you have problems with reading? Do you have problems with tracking? Do you skip things on the line? And so what you do, and something simple that they teach is like you first start to have them focus. You could do this in the clinic or even with thing. You have them hold out their hand and focus on their finger. And I mean, most people's arm is hopefully at least a foot or 2 feet away, and you have them bring their finger to them and ask them when they start to see two objects. And that should be 3 to 5 inches for most people. If it's more than that, they probably can have convergence problems. And then you ask them to start tracking. So I can show you here, if I start doing that, my eyes do not track together. So I have an example of that. And it can be very easy for that to do that. It can look like strabismus. Their eyes are not tracking together. Another thing that we did in pediatrics, you can actually take a pen light and in gross pupil asymmetry, what will happen is the light reflex is not symmetrical. So that light reflex, if they're looking straight through the camera or straight at you, the light reflex should be symmetrical in the pupil. So it should be symmetrical. What happens is it gets a little off or down or like this. And so one thing that I've had one veteran say is she was planning to go have him take selfies of himself when they're looking straight at it. If they have glasses, they have to take the glasses off because they might have something called prism, which I'll talk about. And so this is one thing that they have problems, especially with TBI, with head injuries. There are some disorders like hypermobility with Ehlers-Danlos that can cause this, where they have intermittent. So this means when they get really tired or when they get stressed, that's when the brain starts having problems with the tracking of the vision. That's a huge problem after a head injury. And so they have a hard time kind of focusing from near to far. And so they'll have something called a cover uncover test. We have a vision therapist and our neurooptometrist who will work with this. But these are things that you can do very easily, especially with the extraocular ones, and as well as asking them to do certain things. So a lot of them will feel like they have attention problems because they can't follow things very well, especially if you're having them follow the finger and they feel like they're getting sick from doing that. They lose their space easily when reading. They start skipping and missing lines, and they can't read as fast. They also get really dizzy with tracking objects, as well as they're very light sensitive. And so this kind of shows you some of this. So they can get dizzy, disoriented. They might have a problem with visual memory. These are all from the eye tracking problems. And so this is a sign that they either have something that's usually that goes on with a post-traumatic headache, because they're trying to do this. So if you think about, there's also the computer vision one that people can get. They have a hard time working for hours because their eyes are not tracking correctly. So one of the things they'll do, you have color lenses. That's kind of like what I have here. I have another example. This is like another ones here. They're FL41. So ones you can get even online are like this. Are ones from online from Amazon. They can get over glasses. They have clip-ons that they can do. We have a vision therapist here who can get them. This is from Chadwick Optical. Those pink ones over there are actually from Zenny. That's what these are from, where you can actually get a prescription of those, or you can get clip-on ones. But the vision therapist will get nice wraparound sunglasses that will actually help dark ones and then lighter ones in this one, because oftentimes if they've had LASIK, they're told, go ahead and get yellow lenses that will help you with those halos at night. But that's actually a misnomer, because it lets in more light and will make their photophobia worse. And so what they want, especially if their eyes are having problems with tracking, is something called prism. And that will actually help them, the eyes turn in the correct way. And so that's what they do with kids with strabismus. So hearing is another challenge, because a lot of them will have tinnitus and vertigo. And so the ears are connected. The other challenge to hear too, migraines hit the disorder of the trigeminal nerve. So trigeminal is V1, V2, and V3. And so oftentimes they can actually mimic, and people will think that it is a sinus migraine. So, or sinus headache. Sinus headaches are actually thought to not, unless you have an actual goopy stuff going on the back of your throat, or fever, it's probably not a sinus headache, because again, V2 and V1 right here, people with migraine will get a lot of pain right here. And in the AHS actually said, the American Heartache Association really encourages almost any sinus headache to be treated for migraine in the absence of actually allergy symptoms. And so the other ones you'll have are something called vestibular symptoms. This is a lot of dizziness and something called visually induced vertigo. So if anybody has gotten dizzy or had this where you get really nauseous, that can cause an incredible amount of anxiety. I'll go through this one. And so this is the sinus headache part. Again, you can actually have it, your distribution of your trigeminal nerve is here. The other problem too is ear pain. So I don't have a headache. I just have a lot of ear pain. Your eustachian tube dysfunction, they'll think it's that. But again, that's right next to that trigeminal nerve, V1, V2, and V3. And so oftentimes they can actually have a sensation of ear pain, ear fullness, like they're underwater or some water is in the ear, which can be very anxiety provoking. And then they're told that they're either imagining it for our patients. So this is a big one right here. A lot of times they're told, oh, this is in your head. So they get very motion sickness. This is a big one to ask about in their history. Did you get motion sick as a kid? For our veterans with a history of head injury, this is one of the most common things, is that vestibular migraines can occur after head injury, because this is what happens once they've had, whether it's whiplash to an explosion, they can get this easily. So I call this your predictable panic attacks. Panic attacks, we know, are not easily triggered. So they get, hey, I get panic attacks every fall, when the weather changes. This is when it happens. This is a great sign that might be happening here. So they have a threefold odds of increased depression and anxiety compared to other adults. They have perception to changes in body and motion, and they can get really, really sick. And then they're told that's your panic anxiety. So a lot of them might get misdiagnosed as functional neurological disorder, or are the ones because they're getting really disabling vertigo. And so if you see all these ones, I don't know how many of you might have had patients with some of these symptoms. They get lightheaded, they get anxious, they start, having that ringing in their ears, and they're told that's your panic attack. That's interesting, because panic attacks aren't supposed to come with neurological symptoms. But it's kind of the chicken or egg, just like your asthma attacks. And so these will go through here. And then as an example, here is a patient who had a history of long COVID, and she used to have traditional migraines. And then all of a sudden she has, especially in the fall, predictable severe cases of anxiety where she gets those hypothalamic ones where she starts feeling ear pain ringing in her ears, really warm and flushing. She gets severe nausea that GI doesn't even know how to treat her with that. She has to go lie down in a dark room. But I don't get migraine. My head doesn't hurt, so it must not be a migraine. It just must be my anxiety. And so that is actually a great example. But she moves her head funny, and she watches picket fences, watches movement like an escalator. That can trigger her panic attack. And so that's interesting because, again, panic attacks are not triggered. And these vestibular symptoms can actually go throughout the entire migraine. Again, they might actually skip the headache phase because you can have something called silent migraines in the sense. So now with the aura phase, an aura is a reversible neurological symptom. It can be visual, which is the most common, auditory. So sometimes these can be mistaken for auditory illusions where people think that they're hearing something, especially if it's tinnitus, white noise, like that. They might think it's someone speaking and they get mistaken as a voice. Language, they have difficulty speaking, reversible motor symptoms. Smells, all of a sudden, things smell really, really bad. If they have a history of trauma, they might be smelling something from trauma. I think of this, all of a sudden things are smelling like acetone, food smell and taste bad all of a sudden. That can be a sign that they're having some of this one. So I like to show the visual aura here. Again, I've had ones with they're panicking. They've never had a visual aura before. So now, yes, they are going to have a panic attack because they're seeing these light spectacles and they're panicking because they think they're tripping. They're like, I did not take a drug. I didn't take acid. I did not take anything like this. And I don't know what's going on. I've had patients call the triage line and they'll look up and go, oh, you have a mental health disorder. You need to go talk to your mental health provider. And so they're really are terrified now because they don't know what's going on. And so again, the big thing, especially if you want to try to differentiate it from visual, a disorder in the retina versus a disorder in the brain is one of the headache specialists actually said, close the eyes because the visual aura will still be there. So I'm going to show that thing that you see with the banana right there is something called palinopsia. It's a sensation of motion going in slow motion. And scotomata. So hopefully y'all can see this. It's a little video of actually seeing that in motion. So if you see that one in that right lower corner, you can imagine you're feeling this and all of a sudden you have this going on. You start seeing things that can freak you out if you've never had that before. And now you're trying to imagine if you have patients trying to describe this to you, everyone's thinking you're having hallucinations, you're having panic, especially if they don't have the headache that follows. This is something called visual snow. So it's like looking through an old TV monitor. They're still not quite sure what causes that. And so this one, I wanted to show two cases. So there's something called a confusional aura. And so this can be where there's two cases of sudden onset of two veterans where they became suicidal. One of them was a male. He actually history of he had a 20-year history of doing well, high functioning male, and he had a sudden onset of confusion, couldn't recognize anybody in the room, and then he felt that he had to die because the rapture was coming. He went out to a neighbor's yard, pretty much asked him to die, and they tried to help him get to that state by shooting him. Another case, it was a female who had a history of migraines. And when her confusion, she actually started becoming suicidal because she didn't know what was going on. She became disoriented, couldn't recognize who she was. She calls the helpline where they, by that time it clears, because again, aura is reversible, and they diagnose her with a functional neurological disorder. Again, there's one with a male with a out-of-body experience. Again, he doesn't seek treatment, but then his roommates encourage him to come in because he doesn't remember he's having this disorder. And then a 59-year-old female who starts having these confusional migraines for 10 years, she's having these. And with 11-day period where she can't recognize her loved ones. She does have lacunar infarcts on an MRI. Again, she's also diagnosed with a functional neurological disorder. So again, it's interesting here, both females here were diagnosed with functional neurological disorders, which is actually more likely with the females, given the fact that they're less likely to be believed. And so I'm gonna kind of go through here so I can get through the mimics, headache phase, and the post-stroke so I can get to the part. So red flags, these are different ones to kind of look for. And then this is one about that. And so there's a cluster headache, which is also known as a suicide headache. Due to time, I'm not going to be able to kind of go through that. So going back to our patient, Tommy, he actually was telling a case where when he got back from deployment from having all those headaches, he was very depressed. He was in physical pain. He got assigned to something called a rear detachment. And he said he actually ended up attempting suicide by jumping out the Tacoma Narrows Bridge. And he lived through that. But then because of that, they only treated him for his PTSD, diagnosed that, and never got treated for his headaches. Which brings us to, again, I'm not going to be able to go through much of this, but the relationship with headache and suicide. So there's a lot of trait vulnerability, but kind of one of the main things I want to get through here is something called suicide crisis syndrome, which is what one of our veterans had experienced. And this is from Dr. Gallenker, where he talks about these symptoms where they don't necessarily feel suicidal till they have that. And so these are ones that you can associate with headache disorders. And I'll show this one right here. And so you'll see this with sense of entrapment. You'll see a sense of emotional regulation difficulties. You'll have cognitive rumination, cognitive flooding, which can actually develop into a very unique type of headache where they feel like the headache's going to explode. And increased agitation, as well as elevated arousal, and then social withdrawal. So I want to be able to get to treatment here. So usually I don't expect necessarily everyone to become expert in the primary medication treatments. You have your initial mild to moderate ones. You have you have called triptans, as well as your GPANs and ditans, but I want to talk about our neuromodulation devices. This one. So the big one that I've been using here is actually these top three, which are the ones that are available at the VA. GammaCore is the transcutaneous cervical vagal nerve stimulation, which is actually approved for migraine. This is not used as much for the American Headache Association because outside the VA, it's not covered by insurances, but we have actually an opportunity for that to be covered here. So again, we know this is used to treat depression, but the big one here is beneficial for PTSD and migraine. And so I've actually been able to use with veterans. It's my most common one because a lot of them may not want to use this, use another medication. So that's the one that I've been using the most because they can actually use it cervically. I do have ones that they're using on the ear, which is what, I'm going to show this there, which is what Notre Dame is actually using for treatment of teenage suicidality. So the vagal nerve actually helps in nociceptive modulation, cortical spreading depression, which is that aura, as well as the hyperarousal and dysautonomia. It's also used for mental health to help with fear circuits. We know that memories that are formed when you're in a hyperarousal state actually stay there more. And so this actually helps treat that. It helps reduce glutamate. It helps with memory and cognition. Right now, these are all still, the FDA does not like to approve device. They don't approve devices, they clear them. And so although these are approved in Europe and Canada and other countries, they're still kind of they're kind of in limbo here in America, despite a lot of studies. I'm gonna go back here. If you see all these different research areas where they're being used besides just headache, the big one here is really cool benefit to be used for PTSD, depression, and anxiety for our patients. And that's where this is a big winner here. And that's the number one thing I've been using it for. I've had over 120 patients here and over 100 at my last VA that I've been using that with. And they love this device. It's their favorite. And so that's the one that I've been using the most here. And so that's where the auricular device they've actually been using for teenage suicidality with Notre Dame. And so going back to our patient, he actually had a history of cluster headache as well as migraine. As a diabetic, he suffered from gastroparesis, so he couldn't use a lot of antidepressants. So if you, and again, we couldn't talk too much about this due to time constraints, but for triptans, oftentimes I imagine they need the immediate one that is good for the IM one that they use for cluster, or that if the migraine gets worse, 0 to 60 within 20 minutes. And so he got that. He had a nausea medication for his gastroparesis, the neuromodulation device, as well as the cephaly. And he's been doing better, as well as we got him the CGRP antibody, which we didn't have time to talk about. He has the glasses and also consideration for the auditory processing disorder. This is often what I will use to talk with them about when I'm kind of treating them about the device. And so this actually was from September. I didn't get updated with the recent numbers. So summary. I think I got 1 minute late.
Thank you very much for your presentation. So we have time for questions.
My connection was cutting in and out a few times. Would it be possible to get your slides, Dr. Thiam?
Yeah, if anybody wants them, yeah, because I have a lot more information on the slides than I could present because of time.
Yeah, and then I just wanted to share that Dr. Thiam had shown me these devices. I used a demo model with 2 different patients, both intermittent but pretty serious migraine sufferers, and both of them experienced complete remission to multiple migraine events with the cephaly device. So I'm a believer.
Mm-hmm.
Great. Thank you.
Hi, this is Davin Quinn. Can I ask a question?
Please.
Yes, sir.
Hi, Dr. Thiam. I know we've been meaning to connect, trying to connect. It's totally my fault. I apologize, but I definitely need to pay you a visit, at least virtually or in person, when I'm at the VA next. So thank you for that presentation. It was a really sort of you touched on so many important topics, and just I also just want to say it's wonderful to hear about the military culture, military specific occupational hazards and problems, and how that comes to psychiatry, because New Mexico is such a military involved state. And so this is something that I definitely think that is important for our faculty and trainees to know more about. So thank you for presenting on that. I have a question about the cephaly. And so I just am curious how do you instruct patients to use it for the different indications? Like is it once a day, twice a day,
cephaly or the trigeminal one?
The cephaly, the one that your colleague Dr. Patz was also sort of referring to. So
so I've been using the gamma core the most. Cephaly is the trigeminal one. Let me grab it. I have it right behind. Yes, hang on.
Or if it would, whatever is the one that you sort of say is like the favorite of all your patients, that's the one that I'm just wondering.
This
what are the
is
parameters that you're
cephaly.
advising?
This is cephaly. This is the one. So I've had a couple of them use this one, but it doesn't have as much broad parameters. So the trigeminal one, they're actually using that one. And I want to show the other one, but this isn't available at the VA yet. It's actually being used for depression, and it has like 12 different sites being used for depression. And this one, because it's trigeminal nerve, they're using it for ADHD. And this is Relivian, like this. But this is the gamma core one. This is the vagal nerve. This is the one that has a big win for mental health. So again, they've done this off of the studies because again, vagal nerve, and I had one veteran who actually went and bought the Truvaga, which is the civilian one you can get over the counter, which I've used in my private practice for those who can't get it. And I say, if you want to use that, because the big one is, it is time limited. So outside the VA, it turns off in 90 days. They have to keep renewing it. So that is one challenge, but the veterans, they have that. And so that's where the AHS is kind of bitter about that. in that sense. But they've done ton of PTSD studies. They're doing one at Emory right now with imaging in the brain. And so it's a lot of our veterans are like, where has this been? And so my last VA, if you didn't have a headache disorder, you couldn't get it used. But I mean, some people have been using it just for PTSD and anxiety, stopped a panic attack with it. Because again, of that vagal nerve one.
And for PTSD, do you tell them to use it once a day, twice a day?
Yeah.
For how long? Like,
so I have them, and what I use is I show them that migraine cycle, and I'm going to go back to this. Oh, hang on. Sorry, I don't mean to make everyone dizzy here. I'm going to go back through this chart. I'm going to do that little polyvagal theory chart right here. Oh, here we go. And right here. So I'll use this one right here. And what I usually explain to them is how so many of them, especially whether it's PTSD or even a migraine, they get caught in that yellow orange area. And so whether it's migraine, whenever they have it, even that prodrome, I say, treat the prodrome early. This is the one thing, even though gamma cores, FDA indications for pain, this is the only one that you can use at any point in the cycle. You can't take any medication until you have pain for migraine. Except for the nausea medication. All the other ones, you have to have pain or you risk medication overuse. The neuromodulation devices, you can take no matter what. I mean, I had Cephaly, the one here for a patient with anxiety. I'm using it for experimental for some patients for ADHD because they have a Monarch device they use for pediatrics in the exact same area. They just sleep with it, which doesn't really work very well because I have a daughter who does not keep it on. But the Cephaly works better in that sense. So for concentration, and it's really good for that acute pain with that deep pain right here in that sense. So I have actually used both of them because one of them, again, they just can't use them at the same time. And so that's really good at really deep pain right here. I had one of the confusional migraine patients. She had the first actual painful migraine that she had, and it actually stopped her one. Most of them will get this one because they're really good with those 80% of that non-head pain. That's where it's the strongest because it's been used. The Air Force is actually using this for the pilots. They're using this to use it for stress. So when you're going into an exam, when you're going into a pilot, they need to be focused. They don't want to be kind of aroused. And then when you're think about coming off of code or a patient emergency where you're kind of aroused, you need to be able to come down again. You need to come, and as I say, go towards that green. You put on the gas, and you need to be able to put on the brake, and that's what happens. You need the vagal brake. In PTSD, we know it's a bad brake. And so that's where that came out wrong. We know we have a faulty brake with PTSD. And so that's where the vagus works really well in that sense. And the trigeminal works really well with that concentration. And so actually using them very well together is actually very helpful. And here we've been able to do that. Last VA is like, they can only use one device. And I'm like, well, why? Because they use multiple meds. And so I've had veterans get off of meds because they're like, I'd rather use this.
Dr. Chan, there's another question, and we have time for that real quick.
Right.
Hey, Dave Earl here from psych and sleep medicine. I kind of work between the two departments, and I missed a portion of this. I'm looking forward to slides because of Dylan talking to a resident about the inpatient issue here. But for 1 in 4 adults have obstructive sleep apnea. 80% of them don't know they have it.
Oh yeah.
PAP acceptance has gotten better with our auto devices and more comfort in the mask. But what I found is if it's a headache patient, they're all in because it particularly if they have moderate to severe obstructive sleep apnea, although sometimes in traumatic brain injury, we see central or both, and we have ways of trying to sniff that out and mitigate it. It can help with reduce frequency of headaches. And so usually in claustrophobic patients, I'll just say to the group that they usually do very well on positive airway pressure if they need it, because they actually are getting air. So that's not as big a hurdle as some people may fear. I have to say that our VA here has a little bit more of a utilitarian model as far as it will typically do home studies, even though there is an in-lab over there. And those are not considered as accurate. If they're positive, then yeah, you can use the data. If they're negative, they're really meaningless. Their specificity is not such sufficient. So fascinated by this topic. Thank you for presenting today. I think a number of us here are. and let me know any way that I can be of assistance. We do share some
Yeah.
folks between the two, including some active duty folks and whatnot, and happy to do what we can over at Sleep Center to try to help out
Well,
those who have served our country.
Let's say at the sleep center, one of the big issue we have right now, I've had some veterans who say they're waiting on devices and they're like, I mean, I had one who's dropping down to 50%, and I don't know
Terrible.
what's,
It-
and I'm like, what's going on with the devices? I had
There
one saying he's
was-
waiting 5 years. I'm like, that's before the recall.
That's not quite the full story, but there
Yeah.
was like a Coke and Pepsi, and Pepsi recalled all of their products because of
Yep.
foam degeneration issues with those that were using
Philips.
ozone cleaners, which shouldn't be done. So
Yeah.
that was Philips Respironics. They're
Yep.
still recovering from that. It essentially overwhelmed the competitor immediately, who has recovered from that. And so setups now there can be a few challenges, purchasing in the VA. I'm a former government employee myself, completely understand. But we've kind of recovered from the shortage. And so if somebody's still waiting, it may just be that their order needs to be resent, or they haven't had a face-to-face within the last 6 months.
Oh, they've been told they're waiting. Because they've checked out all of them. I keep asking the sleep clinic. So these are ones.
So you're asking the right people over there. So Nick Cutrofello there at the Sleep Center
Okay.
at the VA is usually a very good point of contact for, hey, can you tell me what's up? And he'll give you a pretty reliable answer. But here in the civilian side, that's gotten better over this past year.
So I know the civilians have gotten it, but the VA, I mean, I had one couldn't get surgery because he was told to bring his CPAP to the surgery center.
Yes, we do surgical clearances, and yes, yes, that is true. That is true. So we try to facilitate those folks through with about 4,000 or so consults are pending. Like I say, 80% of people don't know they have it. Most of them are sleep apnea, but these TBI, neuroatypical, movement disorders, those things are of interest to us. We have an REM behavior disorder study that we're doing here and whatnot, that we if somebody is worried about someone here or there, we're happy to work them in.
Yeah, they've used the devices in a TBI study because they've actually used that to help them with cognitive performance when staying awake for the Air Force, as well as falling asleep. And I tried to figure out, how do they do both? Well, because they both put you in that orange area, is what I call it, when you're trying to fall asleep and you can't, and as well as when you're trying to stay awake and you can't. And so they use the device for both.
My understanding is they'll help kind of augment delta activity in the frontal portion of their brain, which is kind of one of the stages of non-REM sleep is predominantly delta, or at least 20%. I see these people in our 6-channel EEG leads that we run during sleep, which is how we know if somebody's asleep and what stage they're in. Particularly the PTSD crowd that have increased fast activity, usually consistent with anxiety spectrum disorders or a PTSD spectrum, and they're essentially sleeping like dolphins. Like their brain is just more active at night than your kind of control, if you will. And cutting into that through things that we do here in psych really helps.
Now the cephalese actually increase oxygen to that, because that's why they looked at, which is interesting because they haven't got it approved for cluster, but they actually see that increasing oxygen. And so cluster has been actually one of the biggest one linked to sleep apnea.
Thank you for your time.
I can't see if there's a question where the questions are. So
we got a few people that said they had to run. One question is, UNM or the VA using biomarkers for TBI? That was from Dr. King over at the VA. I'm not sure if he's still on, but he was interested in knowing that.
Biomarkers? I don't know what they would use, because I would I mean, they have ones, because again, one of the things that they actually are using for, they did in the studies for PTSD is they actually looked at the IL-6 changes. Like when they use the device, they actually looked at changes in the IL-6, and then they've also done one on HRV. But I don't think they're using that at the VA. It's too fancy. Well, I shouldn't say that. It's not. They're not, it depends. Like the Emory's doing that. They're using functional MRI to show changes in that one. So it depends on which one, because I don't know if there's any identified ones that they're regular doing. So I think those are just in the studies.
Let's see. He may have had to run the clinic or something, but we'll see if he sends you a Teams message or if you cross
Okay.
paths with him. Is he here or is he out of CBOC? Mark
He's
King.
PMH. He's PCMH.
Oh, okay. So maybe cross paths with him and answer that formal. And that's the only question I see in the chat here. Everybody else was thanks, and it seems like they really appreciated the content today.
All right.
All righty. Take care.
All right. Thank you.